So I'm going to take a moment to introduce IHIE and a little bit about ourselves. We are connected to 38 health systems that represent 117 hospitals within the state of Indiana. And just a little bit more information, that represents about 15,000 provider practices, of which there are 40,000 different providers. We have about 13 million patients in our repository and represents 11 billion data elements. Our board composition is made up of hospital system CEOs, healthcare associations, academia, state and community leaders. We have a deep partnership with the Regan Street Institute, which is a health informatics research center that was instrumental in the creation of IHIE and our Indiana Network for Patient Care. We are also a 501c3 supporting organization, which is an important distinction. We are made up to serve our supporting organizations. These two graphics represent just a little bit of the breakdown and the footprint that IHIE has within the state of Indiana. As you can see on the left side, we have each of the 117 hospitals, and you can see the full coverage within the state. One of the things I want to mention is there are only just a small fraction of hospitals within the state that we don't have coverage to as part of our network. On the right-hand side, you can represent all of the physician practices. And one thing to notice is there are those that are within the state of Indiana and those that are outside. And this is a result of our provider products that deliver to physicians nationwide. Our customer base is comprised of health systems, payers, government entities, long-term post-acute care, physician practices, many public health organizations, and lab imaging centers. One thing to note is while they're primarily in Indiana, we are working very hard to expand those borders beyond the Midwest. I'd like to take a minute now to describe our services, a particular of our IHIE, which many folks get confused. This is a great slide that really produces a tremendous dialogue to understand exactly what IHIE does or an IHIE does. What I really want to talk about is the data sources on the left, and these are all the individual puzzle pieces that put together a complete patient's record. You've got the patient who goes to a physician and goes to a hospital to get lab tests. So that data can then be pulled into a health information exchange or from a hospital to a health information exchange. Additionally, you also have lab imaging centers, public health data that goes into an IHIE, as well as claims and payer information. All of that makes up a component and a piece of that patient's record. IHIE does the difficult work of pulling that data together into a normalized repository that is really, really tough to do, and we can do it at scale. The other component of that is the data stewardship. So we are the data stewards, and we have the responsibility to protect that data and disclose that data under certain governance approvals. And when we do that, we can provide some of that value-added services. So we can look at that clinical longitudinal record. We can provide some great products and services for the ACO and population health products. Additionally, we have many services that can really work well with the federal government and the public health side of the business. And I want to take a little bit of time now to spend and really dig into some of the solutions. With the population health products and services that we're able to offer to our clients, we can offer our ADT alerts, which is an event notification. Anytime a patient shows up in an ED setting, we can provide those alert notifications to a care management team. We also have care manager access, which allows those care managers full longitudinal access to that patient repository. Additionally, we also have our clinical values report. This is packaged clinical data and useful outputs to support care management, population health, and quality reporting. While our mission is Indiana-based, we work very closely with those institutions that go outside of the state walls as well. So we work very closely with the State Department of Health, the SSA, the VA, and some of those great partnerships that we have with those organizations help build products and services that can be used for those public health initiatives, such as our public health emergency surveillance system, our communicable disease reporting, immunizations, and transition of care requirements. And the reason we're able to do all of the innovative work that we've talked about is the robust system that we have of that large data repository. Like I mentioned, it contains nearly 11 billion clinical data elements. We have that repository and that governance structure. We've built an aggregated clinical data for the patient or a population. We have both payer and providers that have contributed into the repository, and we have real-time interfaces. Additionally, one of the really cool features is a medical research opportunity that we have with the partnership with Regenstrief, and so there's a lot of other outside benefits that are part of the system. We've talked a lot about the repository. Now let's get into the granular details of the data. And we understand that there's a wealth of data housed in an IHIE, and we've talked a lot about those different data sources. Most of those organizations typically think about that organizational or that layer just underneath, which is that structured data elements, that lab, your ICD-9, ICD-10, RX norm type codes. But there's tremendous value in all that data that we're able to unearth in that unstructured data elements as well. So we can really pull that value from both structured and unstructured data elements so that we can package it together and provide outputs that are meaningful for our clients. And I really wanted to dig into a specific case study that we could talk about. One of our many partners, Indiana Bioscience Research Institute, needed access to some data from the Indiana State Department of Health. And they started with the State Department of Health and realized that it was going to be tremendously difficult to collect and assess all the necessary data, so IHIE became that logical choice. And what we did is we created data extracts within certain parameters that they had set up. We coded those specific results outside of many different organizations so that it was a normalized set of data, and then we provided that data back with results and the explanation of the methodology so that they could do some of their analysis. So really we want to talk about what's next. Where do we go? Where are we headed? What can our organization help bring to the new market? As we know, it's not a new concept, but we're still figuring it out. There's this great quote that resonates with me. It says, "Great physicians did population health many generations ago, and it's been lost in the blizzard of technology." And here's some of the things that we're trying to do. We're looking at different analytics tools and big data so that we can examine those very important health issues. We have social determinant of health. How can we pull in all of that non-traditional healthcare data? We're also looking at quality measures, but we're trying to figure out which ones are meaningful. We look at that increasing near real-time data needs and how can we use that most appropriately. And also looking at precision medicine and how does that fit into the big picture. And here are some of the ways that we've identified that IHIE can be a major contributor into the population health space. We can provide some of that informational intervention. We can look at health improvement programs and how we enhance those. We can add data elements to that. We can look at that quality and effectiveness, how we can provide data to help measure those important outcomes. There's also the value of claims and clinical data. Many groups only rely on one but not the other, and I think there's an opportunity for IHIE to play a part in that, as well as that physician attribution, which becomes increasingly tough to do.